If there's one thing we're all taking away from the Lindsay Clancy trial, it's just how fragmented the US healthcare system can be. Because what do you mean you didn't access records from her other psychiatrists, or you weren't aware that she called the suicide hotline? And I'm asking these questions because I think they surprise a lot of viewers of this case, but as someone who's worked in healthcare for multiple years, this does not surprise me. And in this video, I want to explore the gaps in care coordination that exist in the US healthcare system and what efforts are being done to close them. Hey, I'm Shami. I'm a healthcare management consultant, and on this channel, we discuss all things healthcare finance, policy, and operations to help you navigate the system better and save money. Let's get started. By now, you're probably familiar with the Lindsay Clancy case, and you know that she has admitted to murdering her 3 children. But her defense is saying that she did it because she had postpartum psychosis, and the hallucinations told her she had to kill her children. And as part of that defense, they are really attacking the US healthcare system and some of her doctors because what they're finding is that she was on multiple medications, which they're saying worsened her condition. And they're saying her medical providers weren't always talking to each other when they were treating her, which further contributed to her deterioration and eventual homicide of her children. Her now ex-husband, Patrick Clancy, who was married to her at the time of the murders, testified that she was prescribed 13 different medications in the months leading up to the murders, and that she was taking about 3 to 4 of them at a time. Now, I want to say that there's nothing necessarily wrong with taking multiple medications at once, because that might just be the way you treat certain conditions. But the problem starts to arise if no one has a full picture of what the patient's medical history or their medication is. And we see this with Lindsay Clancy's care because she's seen social workers, nurse practitioners, psychiatric doctors. She's been seen inpatient, outpatient. She's called the suicide hotline. And you get a sense that there's not one person quarterbacking her care. Now, this was really pronounced when nurse practitioner Gelada took the stand and testified that she treated Lindsay between November of 2022 to December or January of later that year, and she did not access the records of Dr. Jennifer Tufts, who is one of Lindsay's psychiatrists and also saw Lindsay during this time period. Nurse practitioner Gelada also stated that she was communicating with Lindsay after she was discharged from an outpatient program, although she did not communicate with people in that program either. So you get the sense that some of Lindsay's practitioners are not really aware of her care going on with other practitioners, although they continue to move forward with treating her. And so you might be thinking, how is it possible that they did not access her electronic health records from other facilities? Because we live in a day and age where our health records and everything else is electronic. So can't you just type in her name in the system and then her entire medical history shows up? Well, no. And I know this firsthand because prior to becoming a consultant, I worked as a medical scribe for 5 years in the ER, in the inpatient setting of a hospital, and also outpatient in a hematology oncology clinic. And one of the things I learned quickly is that an electronic health record does not always mean a shared or a unified health record. And here's what I mean. As a medical scribe, I would sit in the room with the doctors when they were evaluating the patients and type up the medical note. But something important that would happen even before then is called pre-charting. And that is when we prepare the medical note by pulling in information from other sections of the electronic health record, such as relevant labs or imaging. And when it comes to the medication list particularly, that section was auto-populated from other sections of the health record. And I know that that sounds great, and it is to some extent, but it does present a few problems. First is that no one doctor's office has ownership of the medication list, and that list can be updated by different providers who have access to that patient's health record. And when there's no ownership for something, there tends to be accuracy problems. So for example, if you saw a doctor and they didn't update your medication list in the system, then when you go and see another doctor, your outdated medication might still appear as active in the health record. Second is that sometimes you're seeing doctors in different health networks. And when that happens, typically the health records from one health system are electronically faxed to the other health system, which means that information there, such as your medication list, has to be manually entered, potentially causing human error there. And this is where a process called medication reconciliation becomes really important. And that's the part of your visit where a clinician will look at your medication list and ask you if you're still taking those same medications, or ask you if there are any medications you are taking that is not on that list. And the purpose of that is to get an accurate and complete medication list. But again, you are sort of limited by the information in the health record to start off with. And it's not only important to understand the medications you're currently taking, but what other medications you've tried in the past to treat your disease. Because if some medications haven't worked out for you, or you've had a bad reaction to them, then your doctor might not want to prescribe a similar type of medication in the future. And this brings us back to the bigger issue at hand, that is, an electronic health record does not necessarily mean a connected health record, because your doctor might have one set of information, your hospital might have another set of information, a program you're on might have yet another set of information. And so unless information is shared, accessible, reviewed, and incorporated into your care, different players might be operating off of different information, which could negatively impact their medical decision making. And that is one of the things that the defense is alleging contributed to the worsening condition of Lindsay Clancy, which eventually led to her murdering her 3 children. Now, these gaps in care coordination have existed long before the Lindsay Clancy trial, and I want to now discuss a couple of efforts that are currently happening in the medical system and currently actively trying to improve care coordination and close some of these gaps. First has been a shift in how physicians are reimbursed. So traditionally, doctors are paid for each individual service they provide, called fee-for-service. But over the past several years, there's been a shift towards value-based care, which is when doctors and health systems are reimbursed for the quality of care that they provide, for patient outcomes, for patient experience, and for better managing the cost of care as well. Now, the dominant model in healthcare today is still fee-for-service, but value-based care has been taking hold more and more. And if we're going to hold a healthcare organization accountable for the care of a population of patients, then you need to coordinate care between those providers. Because under this model, it doesn't work to say, oh, it's the cardiologist's problem, or oh, the primary care physician has to do all the care coordination, or, oh, let's leave it to the psychiatrists. Because if the entire healthcare organization is being compensated based off of how the group performs, then it's everybody's problem. And these types of organizations I'm talking about are called accountable care organizations, or ACOs. And what they are is a group of doctors, including primary care physicians and specialists, as well as hospitals, and they band together to take care of the population of a group of patients, and their job is to improve the quality of care while also managing the spending. And the reason they're incentivized to do this is because if they save money doing so, then they get to take home a share of those savings. And one of the strategies you're going to use to get those shared savings is care coordination, because by coordinating what happens between different groups of providers, then what's going to happen is patients are going to be managed outpatient more instead of winding up in the hospital or the ER, which is a lot more expensive for the health system. And these care coordinators tend to be nurses or social workers whose job it is to connect the care you receive at one facility with the care you're going to receive at another facility. So let's say you were admitted to a hospital, you were treated, and then eventually discharged. Well, a care coordinator would call you after you get home and make sure that you understand your discharge instructions, and they can help schedule a follow-up appointment with your doctor. They can also call your doctor's office to let them know that you were in the hospital, discuss the care you received there, and help you stay out of the hospital in the future. And so a lot of information sharing happens here, which is exactly what didn't always happen in Lindsay Clancy's case. A second system is something I saw while working in the ER, and that's the prescription drug monitoring program. And what that is a state-run electronic database that tracks controlled substances prescribed to patients throughout the state. So let's say you have a doctor thinking of prescribing a patient a controlled substance. Well, what they can do is check this system and see what other controlled substances you were prescribed by other doctors in the state, and that can help inform their medical decision making to avoid things like prescription overlap, prescribing controlled substances that don't mix well together, etc. And this is an important program because sometimes you might not be able to see the controlled substances your patient is already on through your system's electronic health record itself, but you'll be able to see it through this program. Let me know what you think down in the comments below. How do you think the healthcare system failed Lindsay Clancy, and do you think she'll be found guilty or not guilty? And until then, thank you so much for watching, and I'll see you in the next one.